There. So you can, as the participants start to filter in, Sage, you can go ahead and start with the welcome and introductions.
So, good afternoon, everyone, and thank you for attending Gateway's ongoing virtual lecture series. My name is Sage Milne, and I'm a research assistant at Gateway Center of Excellence in Rural Health. Gateway is a rural health research organization that's central mission is to enhance the health and well-being of rural residents through research, education, and communication. Gateway is located in Goderich, and to our knowledge is the only rural health research center in Canada governed by community-based volunteers. We are partnered with several academic institutions and healthcare facilities. Today's lecture is on acute care centralization. What does the evidence really tell us? A topic very near and dear to rural communities in Canada, as many communities can struggle to access acute healthcare services, and which the presenters will take a critical stance on this issue. For this lecture, we have two international presenters on this topic. Dr. Louella Vaughan is a senior clinical research fellow at the Nuffield Trust and consultant physician in acute medicine at the Royal London Hospital. Her research interests include health systems, especially smaller rural and remote hospitals, and the care of acutely unwell patients. Professor John Browne is a health services researcher with a professional background in health outcome measurements and a senior editor at BMJ Quality and Safety. He was the principal investigator on a program which investigated the impact of emergency care centralization on patient outcomes in Ireland. We hope you enjoyed this discussion. And to thank the ongoing attendees, we give diplomas at the end of each semester to those with perfect attendance to recognize your commitment to and involvement with this education series. After the panelists present, we will have a Q&A session. And if you want to type your questions into the chat box, we can then directly ask the lecturers. A brief disclaimer, the views expressed in this lecture may not necessarily reflect Gateway's views or opinions, but we believe in providing a platform for a range of perspectives and thoughtful discussion. Now I'm going to turn it over to the lecturers.
Okay, so I think I'm starting. So can you see my slide deck?
Yes.
Great. Okay, so good afternoon. My name is John Browne, and I am a professor of health services research at University College Cork in the Republic of Ireland. I am also a senior editor of BMJ Quality and Safety, which is the journal that published the recent study of the impact of emergency care centralization in Denmark, and the associated editorial, which was co-authored by Dr. Louella, Vaughan, and I, and which inspired this talk and some others we have given. So in my talk, I will review evidence on the whole population mortality impact of urgent stroke emergency care centralization. In other words, I will not be addressing single conditions or single specialties, single conditions being things like heart attacks. I'll be taking the whole population perspective. So why am I doing that? Because centralization impacts the whole patient population who have emergency conditions, not just the small group of complex care patients where we know it has benefits, such as stroke and heart attack. I will first discuss the Danish study by Flostrup et al., published in 2022. Then I will discuss an Irish study published in 2018 and two smaller regional evaluations from the UK. And these are, to the best of our knowledge, the only studies that also take a whole population perspective on the impact of emergency care centralization. I will then finish by outlining the causal pathways that could lead to harms for centralization. Please note that some of my slides are taken from a presentation given by Dr. Marianne Flostrup that can be found at the link below. So here is the Danish paper we published last year in BMJ Quality and Safety. And this is basically an analysis of the impact of the emergency care centralization program that they have undergone in Denmark using the natural experiment design. So when I present evidence from Denmark and Ireland, I will also try to describe the context of these countries so that a Canadian audience can understand something about how likely it is they could generalize from these populations to their own context, specifically settlement patterns and population density, as these are important considerations when designing time-sensitive care, as you all know from living in remote parts of Canada. Here you see the population distribution of Denmark, which is clearly skewed to the east of the country, where you have the cities of Copenhagen and Aarhus. The darker colors represent more people. The western and southern parts of the country are much less densely populated in Denmark. Denmark is obviously a very different country to Canada in terms of size and population density. For example, Denmark is only 350 kilometers east to west, whereas Ontario alone is 1,500 kilometers east to west. So in 2007, the Danish National Healthcare Authority proposed a reconfiguration plan for emergency care. Over the past 15 years, this has been implemented. It involves the following elements. So fewer emergency hospitals through mergers, the closing of smaller hospitals, building a small number of new hospitals, the centralization of specialized treatments such as for major trauma, the presence of relevant medical specialists at all times, 24/7, and mandatory referral to the emergency departments from GPs or a dispatch center, meaning that patients aren't supposed to be allowed to just pitch up at the hospital. The reconfiguration means the number of acute hospitals in Denmark will go from 44 in 2007 to 21 in 2025. It will also mean longer travel distances for rural patients, and obviously all of these centralization programs always imply longer travel distances for rural patients. So here you see the changes in hospital configuration between 2005 and 2016. The yellow dots represent hospitals with full acute services. So in this rural southern region, for example, you can see that in 2005, there were 4 acute hospitals, whereas in 2016, there was only 1 acute hospital. So to investigate the mortality impact of reconfiguration, meaning to what extent did this either save lives or cause extra deaths, Flostrup and colleagues performed an interrupted time series analysis. So the idea with an ITS, an interrupted time series analysis, is to detect a slope change. Now, why am I talking about slope? Because for any mortality line, it's very unlikely to just be flat over time. It's always either going up or down. And what we want to detect is whether some big health policy change has changed the slope. Now, obviously, when we're talking about death, what we want is for the slope to curve downwards. So ideally, reconfiguration would bend the slope downwards, i.e. accelerate a previous trend towards reduced mortality from emergency conditions. And there usually is a downward trend in mortality just because treatments of emergency conditions, other things being equal, get better over time. A bad outcome would be if the slope is bent upwards, meaning that reconfiguration has lost some of the existing momentum. And arguably, it would also be bad news to find no change in slope, because all of this is supposed to incur benefit. It's not supposed to just carry on as before, because we are putting a lot of extra burden on patients, especially rural patients, and the health system. And if we're going to do that, then presumably there should be some benefit. And unfortunately, there was no benefit. So for in-hospital mortality, there was no significant change in the existing trend. And for 30-day mortality, there was actually a significant slowing of the existing momentum. So this is not a good result. Remember, the main reason centralization is proposed is to make the system safer and to improve patient outcomes. The idea behind centralization is that smaller rural hospitals are unsafe places to receive emergency care, and therefore they all have to be transported long distances to big, fancy urban medical centers where presumably outcome is going to be much improved. And if that isn't the case, the question has to be asked, why are we doing this? Why are we transporting all these patients these long distances to have exactly the same outcome as they were before. And also, let's take a second to reflect on the baseline trend in Denmark before reconfiguration. If this is the pre-reconfiguration trend, then why are you doing anything? If you are already having an annual reduction of 5.5% in mortality from emergency conditions, where is the urgency? Why is there such an urgency to change a system which seems to be so successful? Now, here is the Irish paper, which my team published in 2018 in BMC Health Services Research, using fairly similar design. Here you see the population distribution of Ireland, which is clearly skewed to the east and south of the country. So the yellow and red colors represent more densely populated areas. The western seaboard of the country is much less densely populated, places like Galway, Mayo, Kerry, and Clare, and Donegal. For scale purposes, here you see a small rural hospital that lost its emergency department about 10 years ago. And now patients in this area have to drive 82 kilometers to Cork, where the tertiary hospital is located and where I am sitting right now. on Irish roads, this means a 90-minute journey. So here you see the current location of emergency departments in Ireland. And here you see the 10 emergency departments that were lost and downgraded to local injury units, which are only open on a limited basis, usually either 9 to 5 or 8 to 8. These were all closed over the period 2009 to 2013. And our team performed a similar analysis to the Danish study. Here you can see the overall trend in case fatality ratios for a basket of 16 serious emergency conditions, including stroke, heart attack, and major trauma, but going beyond those traditional conditions to a much broader group of conditions which are treated by emergency department physicians. And you can see again, the overall trend is very positive and mortality has fallen by nearly a quarter over the period. However, joint point analysis revealed a significant break in the linear trend around about 2007, which is pretty much the point at which the centralisation program began. Before 2007, case fatality had been falling by 3.4% a year, whereas afterwards the rate was only 1.2% a year. Again, interesting to see how quickly things were improving before reconfiguration. This is what was happening before reconfiguration, and to wonder why exactly there was a need for change. Now here I will show you two smaller UK studies that also looked at the whole population impacts of centralisation. In the first study, the impact of downgrading 5 emergency departments was found to have no statistically reliable evidence of a change in mortality. Again, that's not good news. And in the second study, the consolidation of 3 acute hospitals was linked to a small but significant improvement in mortality. However, this study has some limitations in how they dealt with prior trends in mortality, and also the distances here are tiny. So we're talking about hospitals that at that time were only maybe 10 or 20 miles apart. So it's very hard to generalize from that evidence to the kinds of situations we're talking about in Ireland or Denmark, never mind Canada. So just a few more slides before I finish. So why might centralisation be harmful? Why isn't it supposed to work? We all hear about bigger is better all the time. So why might it not work? So, the evidence for the benefits is not encouraging. Why might it not happen? So here are some possible reasons. So first of all, it stresses the system as a whole, and that leads to overspill crowding in hub hospitals. This will happen if planners do not account for the underlying growth in need in aging populations and allocate resources appropriately, and they rarely do. Second, centralisation can harm condition groups where we know centralised care is not superior, especially what we would call difficult presentations in older, poorer patients and those with complicated mental, physical, and social needs. For example, a frail 80-year-old woman falls at home because of antidepressant-associated hyponatremia. Her husband observes convulsion and possible head injury. There is a possible broken leg, which eventually turns out to be a knee fracture, which is not operable. Should there be emergency ambulance transport from the home to a local hospital 20 kilometers away or a tertiary hospital 100 kilometers away? Let us consider, what is the tertiary hospital going to do in this case that the local hospital can't? And remember, these are not rare cases. This is exactly the type of case where we see demand going up and up and up over time. Not heart attacks, not strokes, not major trauma. It's this type of case which is causing the massive burden that we see on healthcare systems at the moment. So what is this tertiary hospital going to do? If the local hospital cannot perform CT or X-ray, review and change meds, because this is the source of the problem, the hyponatremia and the antidepressant, if they can't stabilize a knee that's not operable and transfer to a community rehab hospital, why? Why can't a local hospital do that? These are not high-tech things, reviewing and changing meds, doing an X-ray, stabilizing a knee that doesn't require an operation, and then just transferring to community rehab. Why can't your local hospital do that? And what are the possible harms associated with transfer in this case? The patient is exposed to an overcrowded emergency department and wards in a tertiary hospital a long way away from where they live. And again, this person might be frail, confused, have very little experience with these large hospitals a long way away. You know, the woman's husband now also has to make that journey to see her, and her family also have to make that journey to see her. That's expensive and it's stressful on them. And the husband is also 80 years old. So that also carries a certain risk. And then, of course, there are disrupted relationships with community care. For example, the GP, local community geriatric, psychiatric, psychiatry and rehab facilities. And there is obviously the extra economic and travel burden on the 80-year-old husband. And these points were all made in this excellent piece of qualitative research conducted in the Netherlands. The study makes the important point that emergency departments do much more than just complex care. These are not just places where we treat stroke, heart attack, and major trauma. They do 98, 99% of their work is not that stuff. It's much more complicated stuff. So, you know, that they do, yes, they do standardized teamwork in high-tech facilities, but they also do lots of other stuff where speed of diagnosis is key. The hypothetical example I presented earlier is a good example. Emergency departments also perform a lot of basic medical care where routine medical skills are sufficient, and they perform a key role in physical, mental health, and social care, where collaboration with community facilities is key. And in the editorial I co-authored with Dr. Vaughan, we made a similar point. When we centralize emergency departments, we focus too much on life-saving care, and we ignore all the other important things that emergency departments do. Now, last slide. The final point I want to make is that when we centralize emergency departments, we can't ignore broader population health trends. There is emerging evidence in many countries that peripheral communities are on a worse trajectory health-wise than other areas. And you can see this evidence in the US, in this paper, and interestingly, we also see it in one part of rural Denmark as well, where deindustrialization and population loss has led to worrying life expectancy trends. And we see this in peripheral communities in the UK, and we see it, and now it's a well-known emerging trend in peripheral and underprivileged areas in the United States as well. So to summarize, from our understanding of the evidence, there's no evidence from whole country evaluations that reconfiguration has improved mortality outcomes. The limited evidence we have is not supportive of emergency care centralization if we frame it as about whole populations. We're not denying that reconfiguration of certain services around major trauma, stroke, cardiology is beneficial. We're not disputing those facts, although you know the benefits that they're actually accrued in those areas are sometimes not as large as claimed. But what we're talking about is the whole population, the whole group of patients who go to these services. The evidence base is weak. There are a few studies, mostly weak designs other than the Danish study. And obviously it's very hard to map from context to context. So in Ireland, we only have 72 people per kilometer squared. In Ontario, it's 14.65 per kilometer squared. Denmark, 137 per kilometer squared. So it's very hard to map from context. It's very hard to map from, for example, the Netherlands, which has an incredibly high population density, over to somewhere like Ontario. But one thing that is definitely true is there's very little evidence about what we would call balancing impacts. So very little about impacts on equity, on the timeliness of care, on environment, all these extra cars on the road, on staffing, stress and retention, on overcrowding at hub hospitals, and on the efficiency of mitigation measures. So what is the extra cost and the impact of converting smaller emergency departments to minor injury or acute assessment units? And very little research on patient and carer experience or on the disrupted relationships with local providers. One thing that we do know is true is that there are consistent concerns from qualitative research and survey work about what we would call procedural injustice. So opaque decision processes and imbalances between power brokers. So very poor public engagement, a focus on informing by experts, cherry-picked experts usually, rather than listening to communities. A tendency to diminish the role of public representatives and campaigners, and to dismiss their concerns as populism. Cherry-picking studies so that policies can be sold as evidence-based. Inferring whole population benefits from a small group of complex care conditions, and very ambiguous definitions of success. So, for example, the sales pitch starts out as "this will save lives," and often there's the other side of the coin is a threat. So if you don't allow us to do this thing, you'll be killing people, basically. And then when the evidence emerges, suddenly the goalposts have changed to, well, it didn't kill anyone, to defend the policy 10 years later. And that's where I'll finish there. I'll hand over now to my colleague, Dr. Vaughan. Louella.
Sorry, can you hear me?
Yeah.
Right, good, because I'm trying to sort my slides out and unmute myself at the same time. And there we go. Can you see my slides?
Yes.
Great. And so apologies to the audience for my not being able to show my lovely face. I even brushed my hair and put on lipstick for this. And at the moment I'm just trying to find how to sort my slides out. Right, there we go. Right, so I'm going to talk a little bit more about, so John's presented the main evidence around mortality benefit, but reconfiguration of smaller rural and remote hospitals is also done, as John said, for a whole series of other reasons. And so I'm going to run through some of the other assumptions of why reconfiguration is a popular policy. And in fact, it's been the main direction of policy travel in many countries over the last 30 years. And I thought to start off with, it would be really useful to touch upon the outcomes from the previous reconfigurations of emergency medicine that occurred in Canada. So there were reconfigurations from the late 1990s into the mid-2000s in Canada. This was done on a regional basis. The form of reconfiguration was different in each province, and whether or not it was attached with other structural change also varied from province to province. So in some places, it was accompanied by quite major changes to the way that hospitals and practitioners were paid. There were differences in the amount of care that was done with this. And in some places, there was quite good care to ship resource from very small hospitals, which were basically providing GP, family medicine type services, and moving those resources into local community general practice. And there was also some major reconfiguration of maternal care. And so the outcomes of this were assessed. And the overall outcome, as John said, was the standard, well, it didn't kill anyone. So there was no evidence actually that the care was better, but there was also no evidence that the care was worse. And particularly the outcomes on maternal health, particularly the reconfiguration in British Columbia, has been used as strong evidence to say that closing maternity services in rural and remote areas does not harm your population. And I think there's a real question about how well these reconfigurations were evaluated. So my own opinion, having looked at the evidence, is that these were not well evaluated, and there's been some particularly strong comeback on the maternity work. So this has been since reevaluated, and actually the conclusion from the reevaluation is that mothers and babies died as a result of the reconfigurations that occurred across Canada. So actually the answer is, you've already suffered from well thought out, relatively well executed rounds of hospital closures in Canada, and they were not good at population level. Right, so what are the common assumptions about reconfiguration that tend to underpin it? Well, the first of these, as John has said, is that smaller hospitals provide worse care. Well, the simple fact is there is no good evidence that outcomes are worse for smaller hospitals. So this is a series of studies that have been done in England. And again, I appreciate that there are country-to-country differences that sit in this. But in England, there is no evidence that being small, either at whole hospital level or by individual service, that services in smaller hospitals are necessarily worse per se. This also holds true, or has held true in America, that in critical access hospitals, which only have 25 beds, that is teeny-meeny by any version of the way that you look at it, any way that you define a smaller hospital, the care and outcomes in these hospitals per se is not necessarily worse. There are plenty of big hospitals that provide crappy care. The next one is, as John has said, is all patients benefit from specialist care. Well, that simply just isn't true. So this is a cut of data that we did from a study that was done by the Nuffield Trust, which I led, and this looked at small hospitals in England. And what we're looking at here is actually a data cut of the 20 commonest conditions which occur. And the simple thing is, common things occur commonly. So what are the top 20 conditions? Well, it's infection. It's some cardiovascular disease, so there are some strokes, there is some myocardial infarction, of which NSTEMI, requiring immediate intervention, is not the key presentation, and some falling over and that kind of thing. So, and what we found is that in most smaller hospitals, 80% of patients do not need a specialist. And even then, there are some arguments about to what extent could very skilled generalists provide services. And in most places, they do provide this. So common things occur commonly, and most patients do not need a specialist. They need good, high-quality generalism. Now, there is some evidence that high volumes, particularly for complex surgical conditions, do produce better outcomes. However, for things outside really complex stuff like neurosurgery or having your AAA, your abdominal aortic aneurysm repaired. Now, I don't want that done at a small hospital. I want that done in a big hospital. But for kind of common barn door surgery, like having your appendix removed or having a lap collie done, or again, having a baby delivered, there is no evidence that high volume hospitals produce better outcomes. So again, outcomes at critical access hospitals in the US, 25 beds, by surgical condition, no difference between CAHs and the Mayo Clinic. Not really anyway. And this is a very interesting, the McNally study, the Nally study, which is below that, looked at emergency abdominal surgery in Ireland. Now, what they did find is that the highest volume surgeons in the highest volume hospitals had the best outcomes. But beyond that, the highest volume surgeons in the low and medium volume hospitals had the next best outcomes. And the worst outcomes were the low volume surgeons in the high volume hospitals. So actually, it's not the volume it's not the volume in the hospital, it's probably the volume of the surgeon that really matters. And you can do high volume surgery in a smaller rural or remote hospital. In fact, you may even do high volumes of surgery in those organizations, because you have to operate every day. And as John said, there is a natural assumption that system reconfiguration improves clinical outcome. Now, John has presented some of the evidence for that, but there's also excellent evidence from the USA, which is your closest neighbour. And so the HACER group have looked consecutively at hospital closures, hospital and emergency departure closures across California and across the US. And there is just no evidence that closing these hospitals improves outcomes. And in fact, depending on the way that you cut the data, again, there's evidence that patients die because of emergency department closure. There's a whole series of other issues which are also problematic. And if you look at other studies, it's been demonstrated that closing your emergency department, closing your hospital, increases ambulance time on the road. This increases your ambulance incidence, and there's a trend towards mortality significance in the ambulance itself. It also creates chaos in your ambulance service because rarely is the resource that's put into the ambulances increased when a hospital is closed. Now, one of the assumptions is if you close a hospital, the patients just don't come. Well, and that might have been true some time ago with a younger population of, kind of hardy farmers who have to have their arm ripped off before they go to the hospital. But with an increasingly aging population, that's not true. Closing a hospital does not change the volume. The patients just go to the next hospital over, and that creates chaos in your ambulance service. And this is from John's work and others. You've got increase in waiting time in trolleys, and there's a whole series of other forms of operational strain which occur because you now have more patients in your hospital. Now, this is an important one because my understanding is that many of the hospital closures currently happening in rural Canada are because there's not enough staff. And certainly concentrating staff is the underlying premise with the reconfigurations which are about to start across the Netherlands and across Germany. Now, there's only a small number of studies which have been done on this, but unequivocally, the studies have consistently found that when you close a hospital, the doctors and the nurses don't go to the next hospital over. They frequently leave the system altogether. So if you're, so if your hospital closes, it's not your next town over. You can now go anywhere, and you might choose, for example, early retirement, or you might choose something else. And this applies even in very small systems. So there was a study of a hospital closure in New York, and the next hospital is like 300 meters away, but actually most of the staff didn't go elsewhere in New York. Many of them just left the system altogether. The other thing that does occur, and this particularly happens when hospitals are merged, yes, the clinicians do go to the next hospital over, but you know what? They're not very happy about it. And they are not very happy about this for decades, like 20 or 30 years, they are not happy about this. And we found this in my own research. And the unhappiness can frequently spread and become infectious amongst the hospital. So actually the process of merger can take happy staff at one hospital, you put new doctors in it, actually you make everybody unhappy, and then more staff leave. So in fact, you don't fix the problem, you actually make the problem worse at system level through doing this. So closure of hospitals because you think you're going to concentrate your staff in the next hospital, there is no evidence for that, and you might just make it worse. Reconfiguration has no other impacts on the system. Well, as we've started to see, that is just genuinely not really true. Reconfiguration has major impacts throughout the rest of the system and also on local towns. And the one that bothers me the most is the creation of deserts of care. And this has been seen most vividly in the USA, where smaller hospitals close. They say that they're going to keep some community services there, and they do for a period of time. But over time, over usually a period of kind of 3 to 5 years, it becomes harder and harder to keep staff there. So some staff kind of hang on, but then they retire, and they retire, they're impossible to replace. And then all of a sudden, there's no care at the hospital. This has a knock-on effect on general practice services. So we have seen very clearly in England that even discussion around closing a hospital means that the local population increase demands on general practice. The general practitioners can't cope with the change in demand, and so they leave. And then what happens over a period of time is that you've gone from having perhaps care that was hanging on and not that great, but there was some care, to having no care at all. And this doesn't just happen in rural and remote areas. Again, it happens, you can see it happening in cities in the US. There are parts of cities in the USA, such as Detroit and Chicago, where there are no medical services at all. And as John has said, these areas are usually the poorest and most deprived. So it's the inverse care law. There are major economic impacts on towns. So particularly in a small rural remote area, the hospital is the single largest employer in town. And so when the hospital closes, the knock-on effect, the ripple effect across the town is major. So people lose their jobs. They are disadvantaged by taking jobs elsewhere because it costs them more money to travel. More money spent on travel means less money on their pocket, less money that's spent in town, because frequently it's spent now out of town. And there are substantial knock-on effects across the town. The other thing to say is that you can't then attract people into your town, because if you don't have a hospital, why would anyone who wants to plan a young family come and live with you? You know, if you can't provide maternal care and you can't provide child health, why would anyone feel safe coming to live in your town? So the economic impacts on towns can, in fact, over a period of time, can be devastating. And they, yeah. Well, this is Margate, and I referred to the fact that at Margate they just even talked about closing their hospital, and that's just been a disaster. And as John has said, there are major issues around abandonment, injustice, and inequity. And really, nothing fires up a community more than saying that your hospital is going to close. Well, why is that? Well, people everywhere pay their taxes, and in return for paying your tax, you expect civil services. And the key civil service that you expect is access to healthcare. Now, in Canada, this is actually written into the Health Act that there should be social justice when it comes to access to healthcare. And so, if your hospital closes, well, nothing says that your government doesn't love you like your hospital closing. And so it's no wonder that people get angry and upset about this for perfectly legitimate reasons. And the fact that governments then ignore people's legitimate reasons, I think is really, like John, I think is really very problematic. And I think there's a question around dishonest framing of this, which John has alluded to, because the simple fact that clinicians want big, shiny hospitals. Now, the hospital on the right, the really unattractive grey and blue building, that's the hospital where I work in London, which is an absolutely massive hospital. It was the 5th most expensive building at the time in English building history. And it's not a very good building. We spent £1 billion on it for a not very good building. And the interest on the building is £52 million a year. So we are behind financially even before we start. The lovely, beautiful hospital that you see on the right is part of the Danish Super Hospital program. Ooh, shiny. Wouldn't you want to work or be treated there? I would. And so what the clinicians and the politicians want are beautiful, shiny buildings, because that's a vote winner, right? What the patients want when you ask them is that they want the Mayo Clinic at the end of their street. They want high quality care close to home. And again, that's a completely reasonable thing to want. But really, the patients are happy with decent care close to home. So the picture here is of Belford Hospital, which is one of the smallest hospitals in Scotland. It has 33 beds, and there are ongoing arguments about whether or not Belford should close. Well, Belford is not that far as the crow flies from Glasgow, but you can't because it's got foggy weather, you can't get a chopper in and out 30 days a year. The roads are impassable for another 20 days a year. And even on a good day, it's not that far, but it's 3 hours by train, and it's nearly 2 hours by car across very, very treacherous roads. And if you're in the back of an ambulance being transferred, for just because you've fallen over and broken your ankle, that's not a great outcome for the patient. Thank you. Any questions?
I'm going to say thank you to both Louella and John for excellent presentations. We do have a question in the chat that I'm going to direct to John. So John, the question is, in Denmark, what if any, did centralization have on overall healthcare annual expenditures? So looking at the cost.
Well, if you want to, it's very hard to detect associations between policies which just affect one sector and overall annual spend. I will say that it hasn't been a cure. So spending in Denmark has gone from about 8% of GDP in 2000 to 11% of GDP in the current terms. It's always difficult to know exactly how to accurately measure health spend. It's gone up by about 300% per capita over the same period. So in 2000, started out from about $2,500 US, gone up to $7,500 US per capita. But we see the same trends in all over the developed world, so it's difficult to make any inferences. The only study, I think Louella knows a little bit more about this, but the only study that really pinpoints the relationship between the reconfiguration program in Denmark and efficiency is the analysis of length of stay that they did, and that wasn't encouraging. It did not reduce length of stay. I think there was a marginal benefits on weekends and nights, but that was outweighed by the impact of length of stay for people admitted during the day. Louella, is that accurate?
Yeah, so that's true. There was another study done which looked specifically at efficiency, because one of the things that the Danish government wanted was that they wanted a 1%, 5% improvement in efficiency, however it is that you define efficiency. I find the economists a bit fudgy on this. And this was specifically studied, and what they found is, once again, there was a downward trend or an improvement in efficiency anyway, and they did all of this, and there was no change in the trend. So they didn't, and then they claimed that they demonstrated improvements in efficiency. It was like, well, you're getting improvements in efficiency anyway. And so, you've not really interpreted the data that you've got correctly there. So there's no evidence. So what they wanted, it didn't produce. And I think the other thing that's worth saying is that the amount of money that the reconfigurations has sucked up has led to very major concerns about the amount of money that's being spent in the Danish equivalent of primary care, and more particularly in things like the provision of mental health care. This is seen as having been left behind, completely swamped, and then left behind by the time, effort, energy, and money that's been put into a national reconfiguration of emergency care.
Now, I don't want to give the impression that no one has gained from these programs. Large academic medical centers, large academic medical centers have done quite well out of these. The actual emergency departments in these large academic medical centers haven't done very well out of them. But in terms of growing the power bases, growing the financial infrastructure and so on of these large academic medical centers, this has been a success story for them. But that's not our job. Is to talk about populations, and we don't see a large population benefit from these programs.
So I'm going to direct this next question to Louella, and it's really, what is one thing that a community hospital can do to avoid maybe all the non-benefits, all the harms of centralization that are going on?
Well, stay open. So there's an interesting quiz. So the interesting question is to make sure that the right issue is addressed. So reconfiguration is usually used as a way of solving other sets of problems. So the reconfiguration, as far as I can see in Canada, I'm not an expert on the Canadian context. I'm just a very, very, very interested and concerned observer, is that the issue is around the way the hospitals are managed, and that can't be addressed by the community. And then there are issues around attracting and retaining staff. And that is definitely something that the hospitals can materially do. So the Nuffield Trust, for which I work, has just published a piece of research which looks at non-pay staff benefit and what can be done to improve the experience of people in hospitals. And there are things that the hospital can provide, and then there's also things that the community can provide. So Roger Strasser has led the work on how communities can support their local hospitals, and Louise Lowcock has been doing research in Scotland, again, on how communities can attract and retain staff. And this includes things like signposting jobs for spouses, access to schools, making sure that people are when they first arrive are kind of linked into networks of people, so you don't feel lonely and isolated. And there's a whole series of things that communities can do. Now, some of these things are actually, as Louisa's research, it's not published yet, but I was on the steering group. Some of these things are quite hard, and they're not necessarily replicable from community to community, but there are lessons there about how communities can support your local hospital. And the other thing, frankly, and we're not here to talk about activism, but there is no doubt that local community activism can keep your hospital open. So I showed a picture of the picket line from Lewisham, and Lewisham, despite attempts to close it, has not closed. And if Lewisham closed, frankly, my hospital would fall over, because Lewisham Hospital sees 120,000 patients a year through their ED. You know, the notion that you're going to close an ED that sees 120,000 patients a year is just, it's batshit. So I just can't even begin. But certainly, you know, there are key lessons around how communities can also frame the evidence and frame the discussions. And John has done work around this to engage the politicians better.
Okay, then, John, what suggestions do you have for communities and populations to take to support small local hospitals in order to prevent any thoughts to consolidate in larger centers?
It's a difficult subject, because there's a complicated kind of nest of actors here, and you have to be willing to influence a range of actors. And I think the general public, when they're frustrated by an issue like this, their natural instinct is to turn to their local representatives. And that is important, obviously, but there are other actors at play who are often not visible and who aren't necessarily antagonistic. And in fact, I think if the veil was drawn for many of these actors, they would be appalled at the harms associated with the work that they've done. But there's a kind of a veil of ignorance, I think, sometimes. If you work in a large city, it's an out of sight, out of mind problem. The problems associated with rural healthcare are very abstract for people who are at the heart of the decision making. I'm talking here about academics, you know, the people who are pushing some of these supposed studies that support the reconfiguration agenda are often, you know, they're cheek by jowl with some of these, you know, the people who are running the health system, and they don't really understand how to frame the problem properly. So, for example, when you're doing a piece of research, just focusing on what's happening in a hospital and ignoring what's going on in the larger community is obviously a massive mistake. I mean, you're talking about emergency care centralization, and you're forcing people to travel, let's say, 500 kilometers to a hospital. Many people won't make it there alive. So if you don't do the analysis that accounts for mortality at a whole population level, regardless of whether you were treated in hospital or not, then you won't pick that up. So, you know, making more representations to, for example, schools of public health in Toronto, you know, I would get in contact with people there and say, you know, like, we need help. You know, we're also a part of Ontario. Why can't you help us? And then the other, you know, group of actors are the specialist associations. I think coming to those meetings and trying to get their ear, you know, for example, critical care as a specialty is often at the forefront of making arguments for centralization. Anesthetics, the cardiology departments, orthopedics, emergency medicine, making sure that they're also aware of the impacts on rural healthcare, and not just, you know, the hero versions of rural healthcare. I think some people often get carried away with this idea of like macho guys jumping out of helicopters and rescuing people. That's, you know, again, a tiny proportion of what goes on in rural healthcare, and that's not going to solve anyone's problems. Having more air ambulances, the day-to-day grind of running a local hospital is what needs to be on their agendas. And that's just, you know, if you're doing acute surgery or critical care, that should be just as important to you as the stuff that's going on in big fancy hospital in Toronto.
So just to come in there, so John mentioned trauma. So there's extensive data on trauma, and I actually took it out for reasons of time out of the talk. So there is an assumption that centralizing your trauma service makes it better. Now, if you're a country that doesn't have a trauma service, putting a trauma service in place saves lives, because car accidents kill people, particularly children, at a very high rate. But once you have a well-developed trauma service, there is zero evidence that centralising your trauma service makes a difference. And there's now finally been a meta-analysis which came out late last year showing that there is zero evidence in middle and high income countries for further centralisation of trauma services. And we've seen this in the UK. So England spent an absolute matzo bomb on centralising trauma care. So they established it. So previously, all of the hospitals, there's 200 hospitals in England, all of them did trauma. And this has now been centralised into a smaller number of services who have been designated major trauma services. And ambulances now bypass services to get to the big centres. And all they found that this has made absolutely no difference whatsoever to mortality. And they keep trying, so Tarn, which runs the database for this, keeps cutting and recutting the evidence, and they cannot find any group which shows benefit. If you read the studies in detail, they say that the disbenefit has been that they have produced overcrowding at the trauma service sites. And we know from other work that's been done in the UK that overcrowding kills patients, and it kills patients at quite a significant rate. So actually all that they've done is that they've not produced any improvements in outcome, and they've damaged they have increased risk for all of the patients who go to those large centres through overcrowding at the remaining site. And they have, anecdotally, I have a friend who's in the Netherlands, and they have started reconfiguration work in the Netherlands. And he works in a large department, and he just said the increase in trauma cases, and it's only been a small number so far, has just wrecked his department, because the whole hospital, the department is now over-focused on trauma and not in continuing to provide high quality care for everybody else in the department.
Yeah, I just to pick up on a question from Al Lauzon there about efficiency. So first of all, the evidence of that reconfiguration and centralization creates efficiencies is very weak. We don't see any evidence. But I would also say that I would never start from just prioritizing safety and efficiency over everything else, like over timeliness, over patient-centered care, over equity. First of all, we know that there are 6 dimensions of quality as defined by the Institute of Medicine, and no one has the right to sit down and say this dimension of quality is more important than this dimension of quality. Sometimes you'll hear people say, well, there's no point in having a local hospital if it's unsafe. Okay, nobody's arguing in favor of unsafe hospitals, but there's also no point in having a hospital that's so far away from you, a very safe hospital, that you're dead by the time you get to it. And that's another dimension, that's timeliness. It's the same with equity. That nobody has the right to say our utilitarian algorithm has shown that the best way to organize society is to discriminate against this group of people. And if we discriminate against this group of people, then overall outcomes for everybody else will be good. Nobody has the right to make that decision. And the one thing I'd say about rural public services are always going to be inefficient. That's the nature of living in the country. Rural roads are inefficient. Less cars are on them. Rural post offices are on them. Less people use them. Rural schools are inefficient. Does that mean that, as a society, nobody should live in the country, that we should all live in big apartment blocks in cities? Again, it's not up to some unelected, technocrat to make those decisions. We make those decisions as a democratic society together. We don't make them behind closed doors in these kind of formats. And what we see is just bit by bit, those kinds of decisions being made in urban centers that affect rural populations. I come from a rural background, so does Louella, so we're sensitive to these issues.
So we are 5 minutes out, but I just want to direct one last maybe question to Louella to answer. What would be the next piece to be studied to support non-centralization in rural Ontario?
Oh, well, so I'm not, so I must say I'm not aware of the specifics in Ontario, but I think whoever is looking at this needs to start now, because we're already, there's discussions I've seen some of the editorials which have appeared, and I don't know how centralised and how good the data is in Ontario at population level. But based on what I've seen of the closures, you should be able to start tracking changes in sets of outcomes already. And so I have no idea who's looking at that, but someone really desperately needs to be having a look at that population data.
And then as we conclude this lecture, I hope this lecture has invited for everybody new insights into a robust body of evidence considering centralization of acute care services and how other models and countries can inform Canada about the distribution of healthcare services. At Gateway, we continue to strive to increase the health and well-being of rural residents through research, education, and communication by providing providing a range of topics relevant to rural communities. And a big thank you to Dr. Louella and Dr. John for providing a critical conversation on this topic. And as well, a big thank you to our sponsors for their continued support. Without them, the lecture series would not be possible. They include MicroAge Basics Goderich, McGee Motors, Libro Credit Union, Lighthouse Money Management, Sterling Mutuals Incorporated, MacEwan and Feagan Insurance Brokers Goderich, Huron Telecommunications Cooperative Limited, CERH Goderich, and the Legion Branch 109 Goderich. Gateway is a not-for-profit organization with charitable status, and we greatly appreciate and welcome the support we receive. If you would like to donate to Gateway to continue to support this lecture series and other Gateway rural health projects, I encourage you to visit the Gateway website. It's easy. Head to gatewayruralhealth.ca and click on donate. You can follow us on Instagram, Facebook, LinkedIn, and Twitter, or sign up to get email notifications on our website. Our next lecture is on Tuesday, November 7th, 2023, where Hung Nguyen will present on uncertain COVID-19 messages, the perspectives of rural older adults. We hope to see you there. Thank you very much for everybody attending.
Thank you.
Goodbye.